Hello everyone, welcome to this lecture, Descriptive Epidemiology. We are going to describe the disease in case of time, place and person. So the aim of descriptive epidemiology is to describe the hypothesis. Hypothesis is an assumption. We are going to tell at the end smoking may cause cancer. Diarrhea more seen in outside food eaters. Steps in descriptive epidemiology. First one is define the population. How much population is there, age wise, sex wise, which population is doing which occupation, and cultural differences. In children's group, how much, hospitalized patients, how much. So we are going to describe the population base. Define the case under study based on the time, place, signs and symptoms, and based on lab finding. For example, people of X place is having diarrhea and vomiting since 1/1/2024. We have covered here place. The symptoms, time need to be there in the definition of the case. Now describe the disease of time in case of place and in person. So first in time, some disease has short term fluctuation, some has periodic fluctuation, some has long term fluctuations. Usually short term fluctuations we have outbreak. So unusual occurrence of disease in a defined area or a community more than expected frequency is epidemic. So if it is a limited geographical area, that is called as outbreak. Outbreak can be common source, propagated epidemic, or it can be slow or modern epidemic. So common source epidemic divided into point or single exposure or multiple exposure. So point or single exposure common source epidemic. All the cases will be having a single incubation period. There will be a one source. Example, Bhopal gas tragedy. At same time, they all got injured by that gas. Now multiple exposure. Source is common. Here there is one well. Exposure is at multiple time. One is going to draw now, one is later. Prolonged exposure and secondary waves are there. Here all the cases in the single incubation period. Spike will be up, spike will be down. Usually we can draw this epidemic curve only using the histogram. 1 o'clock in the morning, 1 to 2, 2 to 3 o'clock, 3 to 4 o'clock, like that it goes on. Multiple exposure epidemic, secondary wave will be there. So some cases will come now, some case next, some case next. So this is multiple exposure. Now propagated epidemic. Here the source is multiple. This secondary case can act as a source for another person. This person will act as a source for another person. Not only one, for multiple person, right? For example, COVID-19. Now slow or modern epidemics. Slow rise of cases. Cardiac problems, hypertension is slowly they are rising. And then communicable disease, slowly they are coming down. Now periodic fluctuation, we have seasonal trend and cyclic trend. Seasons, we have summer, rainy season, winter and spring. Summer diarrheal diseases are common. Rainy season vector borne diseases are common because lot of mosquitoes, and road traffic accidents are common. In winter, respiratory infections and MI is common, myocardial infarction. In spring season, allergies and viral diseases are common like measles. Then cyclical trend. Some disease comes in a cycle form. Every 2 to 3 years, measles may come. And rubella every 6 to 9 years. Influenza every 7 to 10 years. Like that RTA weekly once. Every Saturday and Sunday there will be a rise in road traffic accidents. Now long-term fluctuation, also called secular trend. Lung cancer, diabetes mellitus, these chronic diseases are in slow upward trend for the past 50 years. Communicable disease, typhoid, polio and all, they are in downward trend for the few decades. Now place distribution. Place first international. In US, breast and lung cancers are common. Japan, stomach cancer is common. India, cervix cancer and oral cancer is common. Africa, yellow fever is common. And national level, northeastern states, drug abuse is, malaria is common. South India, Japanese encephalitis and filariasis is common. Himalayan goiters are common. Central India, malnutrition is there. In rural areas, allergy is common. Animal bites and skin infections are more seen in people living in rural area. Urban area, diabetes, hypertension, cardiac problem and obesity is common. Local clustering of disease epidemic. So for example, John Snow did cholera epidemic investigation. That was a local clustering. And now person distribution. Age. Some diseases are very common in young age, less than 5 years measles, more than 5 years rubella. Middle age cancer is common, old age people atherosclerosis common. Some disease has bimodal distribution like leukemia, Hodgkin lymphoma, breast cancers. There will be a two peak, middle age one peak, old age one peak. And sex. Hypertension is more common in males. Heart problem also more common in males. Female hypothyroidism is common. Obesity and diabetes is common. Race. Black race people has sickle cell anemia. White race people has melanoma. Occupation. Whoever works in the mines has silicosis. Healthcare workers may get TB and hepatitis B. Marital status. Deaths are more noted among unmarried people. And social economic, poor people are more affected with malnutrition, more rich people having obesity. Define the population, define the disease under study, describe the disease in case of time, place, person. Now comes measurements of the disease. In descriptive studies, we have cross-sectional study, we have longitudinal study, we have ecological studies. So using these study, we are going to measure the magnitude of the disease and compare with the known indices, known standard values. Now we'll get an hypothesis. Yes, this disease is more in this population. This could be due to this. Hypothesis must specify the population, cause, outcome, dose response relationship. Increase exposure cause increase in the disease. For example, smoking for long time leads to cancer. This is how we should form the hypothesis. So we are at end of our session. So we have covered descriptive studies. So the aim of the descriptive epidemiology is to generate the hypothesis. Hope you understood the lecture and thank you for listening.